Good morning, PT on Ice Daily Show. It is RJ here out of Las Vegas. Few minutes late getting started, but similar to Jeff, I'm in a new situation, so making sure that I had everything prepared in basically what will hopefully be my new studio for doing the podcast as well. So, um, one thing that I wanted to cover today is what is, I think, a really cool crossover when talking about the dizziness world and and other areas of ice that this is going to blend very, very well into. And what those are both the Jerry PT world from Christina and Dustin, and then the the fitness world with Mitch and everybody that plays in that arena with the ice team as well. So um, just a couple quick things that are coming up, kind of in my world. We're gonna have Eric Chaconis out here in Vegas in the middle of July, so that's just a few weeks away. If you're looking for a last minute reason to get the extremities course in, you're looking for it in Vegas here in Nevada. We've got to get our CEUs done by the end of that month, so it's a great final push for me and my team. But if you're looking for a great course, that one's going to be coming up here with me and basically my entire crew in Vegas. And then myself, I will be traveling out to the Portland area in the beginning of September doing the Dizziness Demystified course, and would love to have you alongside of that. So those are some really immediate ice things coming up on my radar outside of, I mean, just the awesome content that's always rolling out of this machine. We just started our second year of the virtual ice program, so I believe the cohort on that just closed, but within the next quarter, that will be a great thing to hop on to as well. So let's talk a little bit about where some of this dizziness stuff can cross over. And the mark that I want to make on that today is with uh, the dizziness group of people that tends to be our older population, but their symptoms exist from the fact that they're less active than they used to be. Ooh, and we've got Mr. Dustin joining us today. And morning, Andrew and Jordan as well. So the part of Jerry and how this blends over is there's a lot of cases that I see from an older adult standpoint where the patient has manifested their dizziness into a very debilitating condition based off of fear and avoidance behavior type activity. And when I got to work with Christina and Dustin in the sampler this year and talking about floor transfers, this is a huge one. We're talking about somebody that has a tremendous amount of fear if they fell down and would not be able to get up off of the floor. The way that they begin to modify their activity, their behavior, what they do, their day-to-day changes significantly. And where that flows over into my world is oftentimes those symptoms will present as quote-unquote dizziness. The patient will talk to their doctor or talk to their friends and family and say, whew, I don't know, that makes me dizzy. I don't want to do that anymore. And we see this self-fulfilling behavior of limiting their activity, so their skill level drops. And as their skill level drops, they become less confident to do more things. As they become less confident to do more things, their skill level drops even further. And so they just continue to kind of spiral downwards in this sense where what they believe that they can do and what they physically can do shrinks. And as fear becomes more of an issue, that's where clinically we have to override some of those things to give the patient the confidence back to tackle those things that are most fearful to them. So when we worked on floor transfers with Christina and Dustin earlier this year, it was very cool to come back into my clinic and start talking with patients about just a simple question. If you fell down because of your balance, would you be able to get back up? And for a lot of older adults that we work with, the answer was no. And that was actually such a critical miss that I think we were making in our clinic with a handful of our population, that we weren't asking that question and we weren't addressing a very functional and important part of the patient's symptom behavior model. So as we would identify parts of the vestibular system that may have been weak, or how the interaction of their sensory input versus their motor output to postural responses could be improved by doing drills and exercises. Something as simple as getting up and down off of the floor wasn't being talked about and was dramatically specific to the patient's problem. And when we started having the conversation with our patients and saying, we're going to get down today and we're going to work on getting back up, you can immediately see the dread that would fill them and being like, oh my God, well, this is like the one thing that terrifies me the most. But when you give them the correct sequencing and strategies to get back up onto their feet, it's amazing how that single session could be such a huge win. And in doing so, you completely start to change the narrative. And that's what I really, watching Jeff's episode the other day, morning Chris, watching Jeff's episode the other day and talking about the areas that we continually miss, the three things that we can do better at, and looking at like, hey, you know, your back pain and everything that's going on with that, understanding that, but hey, you know, these hips are doing really well. Considering everything that's going on right next door, this actually looks really, really well. And giving the patient, being a hope dealer, giving the patient something positive to walk out of the clinic with, rather than hammering all of these reasons that they're broken. Being able to take a patient that is terrified of if they fell down, and giving them some strategies to get back onto their feet. And maybe it required a lot of assistance. It maybe required a lot of cues, maybe some props to get hands on the things and table and all of this stuff. But the fact that they complete it and they feel like they're moving in a direction that's going to allow them to get better at one of the most important things that they needed is a huge, huge win for them with that. Now, that's where the second part of this blends into everything with Mitch in the fitness field, is most of these floor transfers look pretty ugly. And what we find out is the patients do not have the prerequisite movement, the hip mobility, the strength to move through these positions efficiently. And something that Mitch preaches a ton and is really big in the CrossFit and fitness model is being able to get in and out of shapes fluently and being able to express functional movement and then doing it for reps under some sort of time or load demand. And really, that's where the fitness model of CrossFit and the fact that it's universally scalable becomes such a great way to introduce an opportunity to train these people in a new, unique, and different way. So you don't have Mary doing 3 sets of 10 yellow TheraBand clamshells to strengthen her hips, but you go grab a kettlebell and you're going to say, hey, we're working out today, and we're doing these exercises, and we're going to do an EMOM of goblet squats and some just heavy carries down to the end of the wall and back, and then you're going to squat again here on the side of the treatment table. And I'm going to raise and lower the treatment table for the right height for whatever Mary needs to get it done that day. But actually using more modern fitness training concepts that mimic the functional patterns that we need for what we've got to do to get these people strong again is is such a great reminder when I hang out with everybody from the ICE crew that, you know, this is such a good evolution of what we're trying to do. And the CrossFit world, I think sometimes we look at it and we see the people that are on the CrossFit Games on TV, or the people like Mitch who are super jacked and ripped and are moving a ton of weight and looking like a hot, sexy beast as they're doing it. I'm sorry, Mitch, I had to do it. But the we forget that CrossFit is such a great scalable prescription model. And if anybody follows CrossFit's content from a social media standpoint, a lot of the content that they've been putting out in the last, especially in the last handful of months, but over the last few years, you know, CrossFit is really coming after a chronic disease, and they're championing a lot of older adults that have dealt with years of medication, years of obesity, diabetes, all of the same problem sets that we're looking at in the physical therapy world, and they're shouting from the top of the mountain the success that the CrossFit model is bringing to these people, and so we should be really, really honored of having someone like Mitch as part of our program to be trying to bridge the gap between physical therapy and the CrossFit world in a very, very healthy way and get PTs on board with that prescription model. And so it's not just limited to the gym owner that also does physical therapy, or the physical therapist that also happens to be by a gym and is trying to treat the 20, 30-something-year-olds with some shoulder pain, or help them with their snatch and squat, or things like that. But the whole concept is such an important one that we can bring back into our regular rehab, and finding ways to get people like Mary, who needs to get up and down off of the floor, how to get strong again. And that's going to allow her greater functional capacity to do things like getting up and down off of the floor. And so when you start to marry things like a great fitness concept and look at problems from the Jerry world of getting up and down off of the floor, and someone like me that can sit and listen to those guys talk and then go, oh my God, well, they're not talking about my dizziness population, but this is dramatically applicable to what we need to be doing on a day-to-day basis with our crew. It's really cool to see how this all blends and fits in. And so I plan to have a section for this in my live lecture where we're looking at nondescript dizziness that is not necessarily specifically vestibular weakness or sensory motor changes with peripheral neuropathy, but a generalized deconditioning, fear-avoidant behavior that comes around inactivity and poor health decisions that needs some fitness and needs some functional training from the standpoint of can you get up off the ground? And really that should be the question. Is a big message that's always delivered at ICE courses is why can't it be and not or? As much as we have all of our different content and all of the different areas that we work in, always coming back to the and always coming back to, hey, well, that course isn't directly applicable to me and my population, but when you sit through it and you take in that information, how can you apply it to your set of people? And so really excited. I want to get more content done with Mitch and Christina. I hope anybody out here enjoying today's episode can challenge themselves to take possibly some aspect not related to their direct clinical cohort that they work with, and take a course that seems completely out of left field from where they're at, and then find at least one thing valuable that you could bring back to the group that you do work with, and try to look at things from a whole different perspective than you're usually used to looking at it. Hope to catch you in Vegas if you can make it to Eric's course again. And then also catch you in the Dizziness Demystified course out in Portland in the beginning of September. I'm going to wrap it up for today for this episode, and I will catch you guys soon. Have a great Thursday.